Good evening and welcome. A massive welcome to you all for joining us on this somewhat rainy Tuesday evening. Welcome to this GP Hot Topics clinic brought to you by NB Medical and Cancer Research UK. And I, for one, am really excited to be with you here this evening. This is a really important topic, I think, for us in general practice, and I am hoping you thoroughly enjoy the next hour as both myself and a couple of fabulous co-presenters bring you some of the latest hot topics in the world of urological cancers. So let's start, shall we, by doing some introductions. So firstly, myself, I am Kate Digby, and I'm a GP partner and a GP trainer in a lovely practice in Cirencester, which is at the bottom of the Cotswolds. So South Cotswolds, very beautiful part of the world. Highly recommend a visit if you've never ventured close to Gloucestershire. I'm a bit of a portfolio GP, really, because I also work as a training programme director for our local VTS scheme, teaching all the GP trainees coming through, getting them up to speed and infusing them about this fabulous world of general practice. And I've been working as an NB medical presenter now for lots of years, presenting courses and clinics like this, and also leading on our cancer course. So I'm really excited to be able to do this clinic this evening all about urological cancer. But the good news for you all is that you don't just have to listen to me for the next hour, because I am joined by two fabulous co-presenters. Let's start by introducing the first one, and in true breakfast television style, I shall say, good evening, Richard. Can you hear us, and would you like to say hello?
Hi, yes, I'm Richard Roope. A real pleasure to be with you and unpacking some of the challenges of urological cancers. So I've been a GP for just over 30 years, based in between Southampton and Portsmouth on the south coast, and currently working as one of the GPs in our Rapid Investigation Service, which is our version of a rapid diagnostic centre. I also have the privilege of being the primary care advisor at Cancer Research UK and for the Wessex Cancer Alliance. And for 6 years, I was the RCGP and CRUK clinical champion for cancer, which was just an amazing role.
Amazing. Thank you, Richard. We are absolutely thrilled to have you with us this evening. And we, myself and Richard, are also joined by Will. So let's see if Will's online as well. Evening, Will. Can you hear us? Would you like to say hello?
Good evening, Kate and Richard, and good evening to you at home. I'm so glad so many of you could join us. I'm delighted because I've managed to wrestle a 1 and a 3-year-old into bed. I can hear some rumbling still, but I think I'm safe for the next hour. I'm here. I'm a sessional GP down in Exeter in Devon, and I do lots of hot topics presenting and education with other things like Exeter University. And I'm here as your Q&A person. So I'll be manning the keyboard, and there'll be a couple of Q&A breaks throughout the session. And I'd just love to hear your thoughts, comments, questions on the material. So we'll be doing that. I'd love you to post those in the chat box at the bottom of your console as we go through the session. Don't wait for the Q&A breaks. That gives me a chance to kind of gather my thoughts. So yeah, looking forward to interacting with all of you this evening. Kate, back to you.
That's terrific. Thank you, Will. And yes, indeed, Will is going to be very busy for the next hour, I suspect, as he answers all your questions. So just keep his fingers busy. He is poised and ready for action. So I've said already we're covering urological cancers this evening, and really we're going to focus on 3. We've got renal and bladder cancer first, and then we're going to move on to prostate cancer and really do a bit of a deep dive into the latest evidence and the latest guidelines for us in primary care. You'll find in the next hour we have a few poll questions, and they are designed just to gauge your thoughts on various scenarios that we pose. So hopefully you found that the polls tab on your webinar screen. Have a little look for it now, because I'll be coming back to that in my section in a moment. And hopefully also you found the resources tab. So in the resources tab, there's just some additional key information, some really helpful take-home extra stuff to read should you find yourself with a spare moment or two in the coming days. And then Will's there just really to answer any questions or thoughts you may have. So please just keep those coming. So by way of introduction, as I say, we're going to talk about renal, bladder and prostate cancer this evening, and they all share some similar characteristics, shall we say. Like many cancers, the risk of developing renal, bladder or prostate cancer increases with age. And I think one of the really interesting things about these urological cancers is that, so as a group, they've been amongst the slowest group of cancers to recover during the COVID pandemic. Now, this is seen in some of the latest data that's shown significantly fewer people started treatment for their urological cancer in that first year of the pandemic when everything just shut down. And when I say significantly fewer, I mean it's thousands of patients. Just over 16,000 fewer patients started their treatment between April 2020 and March 2021 than was expected, looking at data taken from England. Now, perhaps more notable is that as a group of cancers, these cancers were really slow to recover. So many cancers, but pretty much across the board, we saw a dip in cancer diagnoses at the start of the pandemic, but many cancers recovered relatively quickly. And these urological cancers were just a bit slow to pick up. And in fact, levels remained below where you would expect them until May of this year. Fortunately, now we're back up and running, but the impact of these delayed diagnoses and perhaps delayed treatment initiations, the impact of that in terms of survival and what that means for the future is as yet unknown. Now, it's interesting is as a concept to think about, why would that be the case? And if you've been following the NB medical cancer research courses over the last couple of years, you'll know that we've talked a little bit about this in previous clinics. It's safe to say that this is a multifactorial problem. There are definite patient features, there are clinician factors, and there are system factors to consider. So let's just sort of think about, what do I mean by that? Well, at the beginning of the pandemic, patients were really reluctant to contact primary care. You remember right back at the start when the pandemic began and when all of a sudden our phones went silent and nobody came to the surgery, patients were reluctant to go out of their houses and present to their GP. They almost, in some cases, trivialized the problems that they were having given the challenges that were the pandemic. And the clinician factors include things like not seeing as many patients face-to-face. We went to remote consulting right back at the start of the pandemic. We're still seeing fewer patients face-to-face now than perhaps we were a few years ago. And that has a knock-on effect because, if we are remote consulting, we are going to be doing fewer point-of-care tests. We're going to be carrying out fewer physical examinations, such as, rectal examinations when you think about patients who may present with prostate cancer, and that's just become the norm for us. How many patients with suspected UTI do you actually physically see in the surgery, and how many of them do you contact remotely? System factors, that are still, having a knock-on effect now include the backlog, for waiting times in secondary care. And also, during the pandemic, certainly at the beginning, there was a reduction in some of the investigations that were on offer. Now, all of that, taking all of that into account, it's really important for us in primary care because if you look at the routes to diagnosis data and accepting that this was data that came out pre-pandemic, primary care it plays a major role in the referral of patients who subsequently get diagnosed with urological cancers. About 70% of bladder cancers and 57% of renal cancers are diagnosed either through referral from primary care down the urgent 2-week wait program or indeed down a routine referral. And as a consequence of that, it's really important for us in primary care to just be aware of the sort of tips and tricks and things that we can do to try and pick up diagnoses a little earlier. When it comes to when do we refer these patients, well, of course, depending on where you live and work in the UK, you are either going to be working from the recommendations from the NICE NG12 guideline, or up in Scotland, you've got the Scottish Referral Guidelines for Suspected Cancer. We know that these guidelines are very cut and dried. There are discrete groups of patients that warrant urgent referral. But you and I both know that actually, the real life patient that we deal with on a day-to-day basis quite often come in with vague or more undifferentiated symptoms. They don't necessarily fit these fairly strict inclusion criteria. So, the take-home message at this point is actually trust your clinical judgment. And if your spidey sense, I like to call the spidey sense, if that spidey sense starts tingling because you just think something's not quite right, well, go with that gut instinct, because, there are studies out there that show GP's gut instinct is really important. We're very lucky now that we've got advice and guidance routes. And I think that, we are increasingly seeing these being quite a good way of getting some quick advice from our secondary care colleagues. Certainly they can inform referral decisions. So don't be afraid to use the advice and guidance routes if you have a patient that you're concerned about and not quite sure what to do. We've talked before in a clinic about the importance of safety netting, but of course, this is just something to start weaving into our day-to-day consultations, encouraging patients to return if their symptoms persist or get worse or indeed change in any way. And we can facilitate sort of good safety netting by scheduling follow-up appointments, or at the very least scheduling follow-up text messages to make sure that patients don't slip through that diagnostic net. And the final message for patients, if you are referring them into secondary care, is to reassure them that hospitals are now, what we like to say, COVID safe. So they have been, hospitals have worked very hard to open up their doors again, and patients need to really take that message away that it's safe to attend their appointments, really encourage them to go to those appointments because it's so important that they don't DNA. So we're going to have a little think about renal and bladder cancer first off. So let's start with renal cancer. Renal cancer is the 7th most common cancer here in the UK. It makes up about 4% of all cancers. And as I said, this renal cancer is one that it becomes increasingly common as you get older, to the point that about 3/4 of those patients diagnosed with renal cancer are aged 60 or more. Now, like many cancers, survival from renal cancer is strongly linked to stage at diagnosis. So if a renal cancer is diagnosed at stage 1, the 5-year survival is in the region of 88%. If that cancer is diagnosed at stage 4, then 5-year survival really drops off and sits at around 13%. And if you look at statistics taken from 2019, about 56% of all renal cancers diagnosed at stage 1 or 2, which is good, but of course that gives some room for improvement. If you think about the NHS long-term plan that came out in 2019, the target for cancer diagnosis in general is to get all cancers diagnosed at stage 1 or 2 by 2028. Certainly aiming for a target of 75%. So there is a bit of room for improvement, shall we say, when it comes to picking up earlier diagnoses of renal cancer. So the most common symptom for renal cancer is hematuria, and that's reflected in the 2-week referral guidelines from the NICE NG12 paper that recommends an urgent referral for anybody aged 45 or above that have unexplained visible hematuria, that's hematuria without the presence of a UTI, or indeed visible hematuria that persists or recurs after a UTI has been treated. Let's think a little bit about bladder cancer then. So bladder cancer, not quite as common as renal cancer, but the 11th most common cancer here in the UK. That equates to just over 10,000 new cases diagnosed each year. And bladder cancer is more common in men than women. And again, it gets more common as you get older, with 56% aged 75 or above. Now, bladder cancer is another cancer where survival is strongly linked to stage of diagnosis. And the survival, a 5-year survival, if it's diagnosed at stage 1, sits at around 80%. So again, really good incentive to get these cancers diagnosed early. Now, the good news story really for bladder cancer is if you look at stage at diagnosis taken again from 2019 data, 76% of all bladder cancers were diagnosed at stage 1 or 2, which is a really good news story. And we should be very encouraged by that. I guess arguably you could say there's a little bit more room for improvement, but we are at least doing a brilliant job of picking up these cancers relatively early. Now, when it comes to risk factors for bladder cancer, don't underestimate the risk of smoking. And of course, when you think about the cancer risk when it comes to smoking, the immediate consideration is lung cancer. Often people then think about oropharyngeal cancers, that sort of thing. But actually, bladder cancer and smoking are fairly closely associated. There's a 2 to 4 times higher risk of developing a bladder cancer if you are a smoker compared to a non-smoker. And in fact, it's thought that about half of all bladder cancers are caused by smoking. Smoking, of course, isn't the only risk factor, and there are many other risk factors, and not all of which I have listed on this slide. The slide would be far too wordy if I'd put them all down. Some chemicals are associated with bladder cancer, and you may well be aware of this association between arolamines, which are found in the sort of dye, plastics, rubber industry, as being as having a significant risk factor for bladder cancer, and that is indeed the case. Now, arolamines were outlawed; they were banned in the UK about 50 or maybe even longer years ago now. But the slightly sticky situation is that there is quite a long lead time between exposure to these toxic chemicals and the subsequent development of bladder cancer. I guess the take-home message there is it's worth asking in occupational history if you're trying to weigh up the risk of bladder cancer to see whether or not anybody has any industrial exposure to chemicals such as arolamines. Other risk factors for bladder cancer include having repeated infections of the bladder, where you've got kind of a chronic, repetitive inflammatory process going on. Family history is relevant when it comes to bladder cancer, and past medical history as well, including renal transplants, which puts the risk of bladder cancer up. When should we be thinking about referring, because we worry about bladder cancer? Again, hematuria is the most common symptom, and it doesn't have to be consistent, constant bleeding. It can be intermittent bleeding. Indeed, I think intermittent bleeding probably occurs in reality more frequently than a persistent, consistent or chronic hematuria. And that's when, of course, the confounding sort of co-diagnosis of UTI symptoms is commonly made. I'll just pop this table up now just so you can almost compare and contrast the NICE NG12 guidelines with the Scottish referral guidelines for cancer. And you can see that there are, half of it's very similar. In fact, it's pretty much identical. And then there are some subtle differences in the latter two criteria. So both sets of guidelines recommend referring all patients aged 45 or above with unexplained visible hematuria in the absence of UTI. And they also recommend an urgent referral for anybody with visible hematuria that persists or recurs after a successful treatment of a UTI. Now, in the NICE guideline, they also recommend urgent referral for anybody aged 60 or above with unexplained non-visible hematuria and either dysuria or a raised white cell count. Whereas in the Scottish guidelines, they just recommend referral if you're age 60 or above with persistent, unexplained, non-visible hematuria in the absence of an infection. NICE guidelines recommend a routine referral for anybody aged 60 or above that have recurrent or persistent unexplained UTIs. And the Scottish guidelines recommend referring anybody urgently that has an abdominal mass thought to arise from the urinary tract. There's fairly discrete guideline. These categories for referral give you a really sort of clear idea on what we should be doing and when. So let's take a patient, shall we? Here's Mary, and Mary is a 68-year-old patient. She is on the duty triage list tomorrow morning. So if, like me, you're duty doctor in the morning, you would see query UTI on the list and probably go, oh, phew, that's going to be a nice, quick and easy one to sort out. So indeed, picking up the phone to speak to Mary, she's had a 48-hour history of dysuria. She's peeing more frequently and she has a sense of urgency very regularly throughout the day. And she's seen some blood in her urine, which is far more obvious when her symptoms of dysuria are more severe. Asking a bit of a broader history, she has no back pain, no loin pain. She's not feverish. In fact, systemically, she feels quite well. So this sounds like a lower UTI. Happy days, so far so good. Just as you're about to click on the acute prescriptions and sort her out with some antibiotics, you perhaps think to have a look in her microbiology just to see whether or not she has had any other UTIs, because she tells you that she's a bit prone to symptoms like this. A quick check of her results and you see she's actually had 4 confirmed UTIs in the last 12 months. So I wonder what follow-up plan you would make for Mary. Mary has a probable UTI. She has visible hematuria, and she's had 4 confirmed UTIs in the last 12 months. So what follow-up plan do you think you would make? You're likely to be treating her at this stage for a UTI with some antibiotics. But in addition to that, would you routinely refer her to the urology clinic given these recurrent UTIs, otherwise no other actions needed? Would you urgently refer her given the visible hematuria? Thinking back to that table that I just put up. Or would you plan to dip her urine again once her UTI has been treated to see if the hematuria persists? Now, I can see we have hundreds of people on the call this evening, which is brilliant. I am absolutely great to have so many people here. So I'll just give you all a chance to think about that. And I apologise for asking you to make a clinical decision at 20 past 8 in the evening. But let's just see what the general hive mind would do. Look at that. So, some would routinely refer her to urology given the recurrent UTIs. Absolutely, she's 68 years old. That would be one option. About a fifth would urgently refer given the visible hematuria. Okay. And the vast majority would plan to dip that urine again to see if the hematuria persists. That's good. Probably of all 3 of those, I would say C, which is what the majority went for, would be the most appropriate course of action. We're just going to have a look at, I think, a really interesting study that was published in the BJGP back in 2020. And this was based in the UK, looking at primary care patients. It was a cohort study that took 1,500 patients that had been newly diagnosed with bladder cancer and had a retrospective look back into their notes to look for stage of diagnosis, presenting symptoms, and pre-existing conditions that may have been a barrier to making that diagnosis. And they made some really interesting observations. The first interesting observation was actually women were more likely to be diagnosed with advanced stage bladder cancer. And the second observation they made was about 36% of men and 63% of the women included in this study who had been diagnosed with bladder cancer had actually had alternative explanations for their symptoms. Most commonly, that was UTI symptoms with hematuria. And this is a type of cognitive bias where we're very trained to think UTI, hematuria, antibiotics done. Whereas actually in 2/3 of the women that had been diagnosed with bladder cancer, this had been the case and may have contributed to their later stage diagnosis. So the conclusions from this particular study was that pre-existing conditions such as UTI that can provide us with these plausible alternative explanations are associated with later stage diagnosis. And it almost serves as a bit of a warning for us, certainly for me when I'm doing my telephone triage, to just have in the back of my mind what else could be causing these symptoms. And it's certainly important to consider bladder cancer as a differential when you're assessing patients that present with symptoms of UTI. And of course, this is something that we're tending to do on the telephone now, so it becomes that much more challenging to do it when you haven't got the patient in front of you. Remember that women are more likely to be diagnosed at a later stage, which, as I've said already, confers a worse prognosis. If you have patients aged 60 or above that are having recurrent UTIs, consider further investigation irrespective of whether they are having hematuria. In anybody aged 45 or above, if they've got visible hematuria, it is really important that we repeat that urinalysis once their treatment is complete, because if that hematuria remains positive, they warrant urgent referral. And this is, I think, a really neat bit of quality improvement activity that you could consider doing in your practices if you don't already have a system in place. This is something that we set up in our practice because we realised actually we were not doing a very good job of making sure patients presenting with hematuria were then dropping in subsequent urine samples in order to make sure that hematuria had resolved. And actually, with the advent of using AccuRx for sending text messages, which has been an absolute blessing during the pandemic, we now have scheduled text messages that go out to these patients to encourage them to bring a fresh sample back in. And we've used one of our care coordinators that are now based in the practice to collate all the results and to chase up patients who fail to present a new sample. That's all well and good for hematuria, because obviously hematuria is a bit of a barn door symptom. Slightly more subtle is non-visible hematuria. And what should we be doing for these patients? Well, the NICE guidance says we should be repeating that dip, and if it's still present, we should be routinely referring to further urological investigation in anybody age 40 or above. What does it mean by if it's still present? Well, actually, that would imply positive in 2 out of 3 samples over a 6 to 8 week period. And we should be referring these patients urgently if they have if they're over the age of 60, if they have persistent non-visible hematuria and either dysuria or an increase in white cell count. Why should we be looking at the white cell count, I hear you say? And this is just, again, this might be something you'd like to add into your workup of patients who present with non-visible hematuria. It's well worth checking the full blood count because unexplained persistent leukocytosis can be a paraneoplastic phenomenon. It's secondary to the excess production of GCSF from the tumours, and it's associated with a number of cancers, including bladder cancer. In addition to sort of being a bit of a marker for cancer, it's also associated with a poorer prognosis. So it's well worth considering doing a full blood count in these patients who are presenting with non-visible hematuria. Right. At that stage, let me pause for breath and let's hand over to Will and see how he's been doing on the questions. How are you doing over there, Will?
Excellent. Thanks, Kate. Yeah, I mean, this is such a great topic, isn't it? And that's reflected by just the fantastic questions that have been coming in. So I'll just pick off a couple of them. It seems as though a few of you are using some clever software. So there's this See the Signs clinical decision support tool, which is integrated into System 1 and EMIS for many people, that integrates some of the data, the risk factors and clinical features of cancer with big data sets to prompt you as the GP to consider a diagnosis of cancer. I mean, this kind of AI-based decision-making is really making its way into clinical practice. So interesting to see many of you have been adopting that. So that was interesting. Lots of questions around diagnosing non-visible hematuria or dipstick hematuria. One delegate rightly asking, do we really diagnose that using a dipstick, or is it better to use a lab microscopy? I think the stuff I've been reading, it appears that dipstick is the gold standard test. Really, that is more sensitive on the whole. But there are certain circumstances where it may miss certain types of myoglobin or other types of hemoglobin, in which case it is good to confirm persistent hematuria with microscopy. But in the first instance, in primary care, we should be using urine dipstick to detect hematuria and referring on that basis. Great question around the role of anticoagulants, DOACs and warfarin. If a patient's on something like that, can we attribute non-visible hematuria to the fact that they're just taking blood thinning drugs? And the bottom line is no. Yes, warfarin can and DOACs can increase your risk of bleeding, but that isn't really a satisfactory explanation. If you've got a patient who's got persistent non-visible hematuria, even if they've had a treated UTI, particularly if they're in those older age groups, so over 45 or over 60, then we should proceed with caution and still refer. And what else have we got here? raised white cell count, yes, that leukocytosis that Kate mentioned, that is, just to clear up any potential confusion, that is on the bloods. It's been found that there's an association between a raised white cell count and leukocytosis on that patient's full blood count and underlying bladder cancer. That's quite a useful insight, something to look out for. Yeah, brilliant. And this is a game of two halves. So we've started with renal and bladder cancers. And I hope we've kind of added some clarity where perhaps before there might have been a haze of confusion. We're now going to move on to prostate cancer, and I'm going to hand over to Richard. Richard, over to you for part 2 of this evening's webinar.
Thank you so much, Will, and great questions, and keep them coming, because I'm sure there'll be lots for this second half. So prostate cancer. So really interesting data looking globally, that basically for most of the world, it is the most common male cancer. So you can see the Americas, a lot of Europe and Africa and Australasia. Prostate cancer is the most common cancer in gentlemen. And that's certainly the case in the UK. And a huge number, over 50,000 new cases per year, averaged over the 2016 to 2018 data collection. So a really common cancer in gents. So the numbers that we've got good and bad. So looking at the good data, 10-year survival is really good, only second to malignant melanoma. So if you're diagnosed with a prostate cancer, 10 years on, 84% of those gentlemen are still with us. Sadly, we have lost 16%. As with all cancers, as we heard from Kate earlier, stage shift can have a really significant impact on outcomes. Early diagnosis, much better outlook. Late diagnosis, not so good. And this is true for prostate cancer, really to quite a significant degree. So if we were able to move all those diagnosed at stage 4 to being diagnosed at stage 3, so still late, but not so late, we could save just under 4,000 fewer prostate cancer deaths would be avoided within 5 years of diagnosis. So really quite significant if we can shift all our stage 4 prostate cancer diagnoses to being diagnosed at stage 3, that would have a really big impact. So got a question here just to keep you alert and alive and not drifting off at all. So what percentage of deaths caused by prostate cancer are in the under 75s? And interestingly, that's what we call premature death. Premature death is defined in the UK as being before your 75th birthday. So you've got just a few seconds to work out whether that might be 10, 15, 20, 25 or 30% of all prostate cancer deaths. What percentage are before the 75th birthday of the gentleman concerned? So just a few more seconds. If you could enter your vote, that would be great. And then we'll see what you're all thinking. So quite a big range there. So 38% running with A, and then decreasing all the way down, but then just a slight increase on the E. So we'll reveal the scores on the doors now. And it is actually 25% of all deaths are in the under 75s. So it's actually quite surprising, because certainly the way that I learned at medical school, that prostate cancer was something that lots of gentlemen died with and not from. So I think it's actually quite a surprising figure that 25% of all prostate deaths are actually in that under 75 age group. So about 3,000 out of the 12,000 deaths we see each year are in that under 75 age group. So really important that we have our diagnostic antennae really well tuned. So unfortunately, or fortunately, whichever way you look at it, there are no identified preventable risk factors. Unlike so many other cancers where smoking, overweight, maybe alcohol may be a risk factor, in prostate there are no identified preventable risk factors. So if you get prostate cancer, it's basically bad luck. There's nothing you could have done to avoid it. So another question, just to keep you on your toes. Prostate cancer causes more loss of life years in men than diabetes. So the way we define loss of life years, it's if a gentleman dies at the age of 65, that would add 10 years to the aggregated years for the population. So just thinking prostate cancer versus diabetes, prostate cancer causes more loss of life years in men than diabetes. Is that true or is that false? And again, we'll just give you not quite so long this time, so you've only got a choice of 2. But once the numbers are in, we'll see whether you back the right horse. And we've got that's almost perfect. I think that's the same as the Brexit vote, isn't it? 49 to 51. Yeah, true, false. We're not quite sure. It's split both ways. It is actually true. I guess actually there could have been a clue in the fact that we're talking about cancer. So really quite striking data there that prostate cancer causes more loss of life years than diabetes. You can see it's only by a small margin, but prostate cancer causes 6.85 adjusted directly standardized rates. So really significant. So it is something that we all need to be aware of and do our best to get those early diagnoses to try and get people over that 75-year mark. So we heard earlier the disruption that COVID caused. It was particularly pertinent in prostate cancer, and we saw urology two-week rate referrals overall dropping by just under 60% by the week commencing the 30th of April. So that was, 3 weeks into lockdown that we had this huge drop-off. And what was notable is that we benchmarked that against the third quarter of 2019, so the sort of last 3 months of 2019. So it's actually the third quarter of 2019-20. So really quite dramatic. And it took until 2021 to recover to pre-pandemic levels, and now they are consistently above them, around about the 20% above. So we are doing some catch-up. The word's got out there that we're definitely open for business. For some reason, they thought we'd shut, which we clearly hadn't, but definitely open for business. And I think gentlemen are now listening to the public campaigns that basically, if you're concerned, make contact with your GP teams. So, as we heard earlier, just over 16,000 fewer people started treatment for urological cancer in that first year of the pandemic. So where does PSA fit into all this? It's perhaps one of the more confusing tests that we can access, and there is a lot of demand for it. And the first thing to say, to get it out of the way, is it's not a great test, and we shall unpack why that is. So only 1 in 4 men with a PSA range in the 4 to 10 category will have a prostate cancer. So in single figures, not a huge percentage. What's more, 3 out of 4 men with an elevated PSA will go on to have a normal biopsy result and no prostate cancer. However, 1 in 6 men with a normal PSA will subsequently be diagnosed with a prostate cancer. So it's very much a case of you can't win. It's a poor test for finding it, and it's a poor test for excluding it. But it is currently all we have. It's also affected by medication, and this is a really important point. So your patients that are on the 5-alpha reductase inhibitors, so finasteride and dutasteride, it actually halves the PSA level from whatever baseline it was. So your referral thresholds, your action thresholds, your repeating thresholds, whatever thresholds you're using, they need to be halved for your male patients who are on that medication. But again, PSA, it's all we currently have. It also rises following UTIs, vigorous exercise, ejaculation, and catheterization. But again, it is all we have. So what about asymptomatic patients? Really controversial. We've got our various incentive schemes going on at the moment that are asking us to case find. It is a controversial area, and there are a range of opinions And I guess from our panel of attendees on this call tonight, there will be a huge range of opinions across the spectrum. However, the current research does suggest that there is no benefit to survival rates in undertaking PSA tests in asymptomatic men. Cancer Research UK has stated that before you offer a PSA test, ensure that you have discussed the benefits and limitations of PSA testing. And there is, you may have come across, this came out a few years ago, the Prostate Cancer Risk Management Programme, a bit of a mouthful, but again, really important that any asymptomatic man aged 50 and over can make an appointment with their GP to discuss having a PSA test. We should not be proactively raising the issue with asymptomatic men, but if a gentleman comes and asks and actually wants a PSA test over that age of 50, they should be allowed to do it. Also important to remember that in black men who have a higher risk, and we'll come to that in just a second, so in black men and those who have a family history with a brother or a father with prostate cancer, the age should be 45 where they can have a PSA test. And there is that detail. So black men have more than twice the lifetime risk of being diagnosed with prostate cancer compared to white men. We're not really sure why that is. It's probably in part genetic. But that is a figure that is consistently found. And also you can see there with family history, it's doubles your risk of prostate cancer if your father's been diagnosed. And if a brother, it's a 3 times increase in your prostate cancer risk. So nice guidance. We've had a little bit about nice guidance for urological cancers with Kate earlier in the evening. But NG12 suggests that PSA should be done with men presenting with erectile dysfunction, visible hematuria, and lower urinary tract symptoms. However, the data that has come through suggests for men with LUTs, the evidence to date suggests that men with those symptoms are at no higher risk of prostate cancer than men without lower urinary tract symptoms. So again, really quite confusing. So as we've mentioned, for anyone over the age of 50 or 45 in the higher risk groups, if they request a PSA test after discussing the potential benefits and harms of testing with their clinician, so either the GP or any of the other clinicians, then in the context of their own values and preferences, we should be enabling them to have a PSA. It would be against guidelines to refuse a gent over those age thresholds a PSA if they've decided they do want one after explaining the pros and cons. So the NG12 guidance, since it was first published in 2012, we have had an update with PSA levels where we should be thinking about a 2-week rate referral, and you can see them listed there. I would say one of the most important ones is those aged over 79, so those past the 80 milestone. You should use your clinical judgment as to whether to refer. I think a lot of urologists say in that age group, if it's in single figures, it's okay to manage them conservatively. But again, our urology colleagues are a little bit split on how to manage those senior patients. And of course, the frailty index would also have a part to play there and would have a bearing on how interventional we should be. So what's the future? How are we going to improve from this rather disappointing test? Well, we do have biomarkers in the pipeline. You may have heard of the Galeri, the Grail test, which is being trialled quite widely throughout England. I think they've got over 180,000 people already entered into it. The other thing that's changed and is changing the landscape is the multiparametric MRI, which means that the investigations are a lot less intrusive and invasive. And it means that a lot more gentlemen will not need to have the transrectal biopsy or the transperineal biopsies. And increasingly, it is the first-line investigation being widely implemented, but it's not yet available across all geographies. So prostate cancer summary. Prostate cancer is the commonest cancer in men in the UK and also in most high-income countries. The 10-year survival is only second to malignant melanomas. That's the good news. Really good 10-year survival. However, 25% of deaths are in the under 75s. So we've got sort of yin and yang, good news, bad news. And I think one of the really significant facts is that prostate cancer causes more years of life lost than diabetes. Amazing statistic. COVID has caused a huge drop-off in patient presentations. They are now coming back out of the woodwork, and the 2-week wait referrals are recovering, but performance is now dropping off once again. And PSA testing is complicated. And just a throwaway comment, but really important, remember to halve PSA thresholds, whatever you're using, for those on the 5-alpha reductase inhibitors, finasteride and dutasteride. And hope rests on current research. So we are hopeful that we will get new biomarkers that will be effective. We're hoping that the new MRI investigation will reduce the numbers needing biopsies. And importantly, it is also able to delineate the what we call the tigers from the pussycats. So we have the really aggressive prostate cancers, but we also have the prostate cancers, which are the pussycats, that are the indolent ones that take a long time to actually cause problems into the future. Really helpful resources from CRUK. These are really helpful to use with patients as well. Limitations, benefits of PSA testing, why we don't have a cancer screening program, and how to support your patients. If you haven't seen these, I would certainly have a look online through the CRUK website, and you can order the leaflets from them. And now it's over to question time. I guess we have a lot of questions coming in.
Oh, yes, Richard, they're flowing in thick and fast. I think you've really got people thinking with that topic. I mean, some great questions. Not all of them I have good answers for, I'm afraid. But one of them is, what about the incidence? What is the incidence of prostate cancer in transgender individuals? So people who've had gender reassignment, or perhaps a non-binary gender at birth and were reassigned later on, compared to cis-trans people who were remain the same gender throughout their life. I can't find, I've had a really good look, I can't find any hard data on this, but I think what it raises is the point that we do still have to consider the possibility of prostate cancer in these patient groups. And it's something I think as clinicians that we are very likely to miss. Great question about this interesting facet of prostate cancer, that it appears to be much more common in Black men and less common in Asian men. Why is this? According to the articles and the myriad observational studies I've looked at online, this is multifactorial, so it's all linked with diet, genetics, and lots of other factors. So it appears to be quite a complex picture, but we do need to be considering as part of our risk profile the ethnicity of our patients. Great question about hematospermia. Now, this is quite a common presentation. I see this all the time in primary care. It causes a lot of anxiety around men. Generally, it's benign, self-limiting problem, but does that qualify that patient for a PSA test? Interestingly, in the NICE NG12, their key criteria are erectile dysfunction, visible hematuria, and lower urinary tract symptoms. So it doesn't feature in the NICE guideline, but I'm sure I've seen it. And Richard, I'd be interested to hear your thoughts on this. Do you think hematospermia would be a good indication for a PSA test?
I think it might depend on the age of the patient. So I would say that if they're below that 50 or 45 for the high-risk patients, certainly there's no guidelines to suggest that. But I think just from a point of view of good sense, I don't think it's necessarily evidence-based, but I think my clinical practice would suggest over 45 in the Black and strong family history, and over 50 in the others. I would just do a PSA test. I think that would be reasonable.
Yeah, great. So you're going to see that. You're going to look at the whole clinical picture. Another good question, this comes up quite a bit, is what impact does digital rectal exam have on your PSA result? We know that drugs like finasteride, the instrumentation of the urethra, that recent urine infection, all of those can have a significant impact on your PSA level, but it's less clear how much of an impact a digital rectal exam. I've done a quick literature review on this, and I can't really find any good definitive studies. All I can say is that there is a question mark on this. It may interfere with the result. And I think it is sensible, therefore, to ideally delay your digital rectal exam until after you've done the bloods for PSA. I know in clinical practice, the natural order of things doesn't really work in that way. But I don't think, from what I've read, it has the same degree of impact that the other factors we mentioned. Richard, anything you'd like to add to that?
Yeah, it's interesting. So through the COVID season, what I was tending to do was you do the history. I would actually do the blood testing if it was indicated, and then bring the patients in for the results of the PSA test and then do the DRE. But of course, if you've got a high PSA, the DRE isn't going to change your management anyway. But actually, probably more important is your patient who has that presentation, who actually has a normal PSA. They need the DRE because of the sort of the 1 in 6 who have a normal PSA but actually have a prostate cancer. So we do have PSA negative prostate cancers.
Gosh, it's such a minefield, isn't it?
It certainly is.
Yes, yeah, and I think such a key take home from this is that the bottom line is we just don't have a very good test. There's so many problems with PSA. There is no good alternative. We have MRI, but it's not very cost effective. And we just have to work with that. And I think that's hard for patients to get their head around. Often they have this expectation that medicine is more binary, that we have cut and dry answers. And I think the role of sessions like this and the patient information leaflet from CRUK, really helps to draw out the nuance and help people have a better appreciation of a lot of the uncertainties around this topic. I've got another great question here around should we be doing, this is from Sarah, should we be doing a screening questionnaire for prostate symptoms? And if so, does this guide whether we do a PSA? Sarah, I assume you're referring to the International Prostate Symptoms Score, the IPSS. Now, my understanding is that is used really to inform the management of BPH, benign prostatic hypertrophy, so men with troublesome bladder outflow and lower urinary tract symptoms, as to whether they should be referred to urology and have more surgical type interventions above just the standard alpha-1 and hormone-based tablet treatments that we use in primary care. So I think that's more geared towards the management of BPH, and it isn't really a tool for sifting out prostate cancer. And I think another key take home that Richard mentioned is that lower urinary tract symptoms, particularly in older men, it's almost ubiquitous. It's so common, and it's not a good differentiator of whether that's prostate cancer or not. Isn't that right, Richard?
Totally right. It's a really good paper in the BJGP a couple of years ago that basically said it is not a predictive factor at all whether you have lower urinary tract symptoms. And in fact, if anything, it slightly leans, I think, non-significantly to suggesting that you've got less risk of having prostate cancer. But that's non-significant. So not a great indicator either way. So makes it even more confusing as to what we should be doing.
Yeah. And Nicola, interesting point here. We know that finasteride can raise your PSA falsely. So we have to we lower our threshold by 50% on patients on finasteride. But is there a link between taking long-term finasteride and an increased risk of developing prostate cancer? Have you heard of any link like that, Richard?
No, not in the literature. So there may be anecdotes, but because it's so common, so you're looking at a 1 in 4 lifetime risk for a black gentleman, a 1 in 8, possibly 1 in 6 for those born since 1960, white lifetime risk. So a whole lot of us are destined to get it. But with a nearly 80% 10-year survival rate, it's not all gloom and despondency. But I think it is just an area we need to be aware of, and to perhaps move beyond the nuance of that it's a cancer you die with and not from, because clearly quite a lot of gentlemen die from it, and a quarter of those, it's before their 75th birthday.
Great, interesting point I want to pick up on here from Hazel, who's asking how informative or accurate is a digital rectal examination in real world general practice. Now, it's still considered good practice by NICE to do a digital rectal exam. And at medical school, I was always taught, if you don't put your finger in it, you put your foot in it. But for those of us with short fingers and who just haven't felt many craggy, cancerous feeling prostates, how reassured should we be by normal feeling gland? Or are you aware of any data on this, Richard, on how well the DRE performs as a clinical tool, or is it just as dodgy as the PSA test?
So we know even with long fingers and thin-bottomed gentlemen that you can only feel about a third of the surface of the prostate gland. And of course, for it to be of any help to an examination, it needs to actually be extending beyond or making the prostate capsules stand out. So it's not a great test. And again, there was a slightly provocative BJGP research paper, I think probably 2 to 3 years ago, that actually said there is a case for jettisoning the DRE because it adds nothing. But its final sentence was, but we need more research before we actually change our clinical practice. So it's not a great test in much the same league as the PSA. So as a clinical area, we're left with more cloudy confusion.
Quite, yes. And of course, it's all, we just have to work with what we've got. One day we'll get these Star Trek style body scanners and we'll be able to just give people a quick answer. But until then, we're down to PSAs and DREs. Well, I'd just like to thank everyone for all your brilliant engagement, and you've really kept us on our toes. There's been some great discussion and questions this evening. And yeah, thank you, Richard. And I'm just going to pass the baton back to Kate to draw things to a close. Kate, back to you.
Thank you very much, Will. And yes, indeed. Thank you, Richard. You boys have done a sterling job of the Q&A section there. Hopefully, just thinking about sort of what we've learned in the last hour, it's clear that the COVID pandemic's had a marked impact on 2-week referrals for urological cancers. And I think it's really interesting to note that this has been one of the slowest to recover. It's interesting to consider whether that is all, partly down to the way that we are now working. And perhaps one of those things to do when you get back into work tomorrow is to consider whether there are any changes that you would make to the way that you work remotely. I think on a personal note, I'm tending to try and see more of those older patients with urinary symptoms than perhaps I was doing 6 or 12 months ago, just because, I just got that slight twitchiness that if I do it all remotely, I'm going to miss a diagnosis. And of course, the problem is with urological cancers, like so many other cancers, is that they often present insidiously or with vague, non-specific symptoms. And of course, that is the challenge, isn't it? It's that needle in a haystack challenge that we in primary care are faced with. So, part of that, I think, is relying upon your clinical judgment. Those of us that work in primary care we are expert generalists. And if your clinical judgment is making you worry about a patient, then act upon that. So ensure your safety netting is in place. Seek advice if you have ongoing concern. I think between Richard and Will, we have identified that PSA testing remains a complicated area. We have got that new updated NICE guidance now, which gives us these sort of age-related thresholds for referral, which is perhaps slightly more nuanced than the blanket refer everybody who has a PSA of greater than 3. And clearly, this is an area where we need more research and we need a better test. I think all that remains for me to do is to say a massive thank you to Richard for giving up his time this evening, also to Will for fielding all of those questions that you've been putting in. So thank you very much, gents. You've done a great job. Thank you to the hundreds of people that have joined us this evening. It's been great to share this hour with you. When the webinar finishes, there will be a very quick feedback survey, and we would all be very grateful if you could complete that, simply so we can see which bits you liked and which bits you'd like to see more of, so that we can refine and improve our plan going forwards. There are more cancer-related clinics coming up. In February, I'll be doing one again with cancer research, looking at health inequalities, which is really good if you think about our sort of DES and our CRUK targets. And also in April of next year, I'm doing one with action bladder cancer, unsurprisingly, considering the challenges of bladder cancer in a bit more detail. All that remains for me to say is a massive thank you for joining us this evening. Hope you've had a great hour. Look forward to seeing you at the next clinic, which will be next month, and enjoy the rest of your evening. Bye for now.